Okay, we will go ahead and get started since we are right at the top of the hour. So welcome again, and thank you for joining us. My name is Megan Campbell. I am the Director of Marketing here at Casamba. I am excited to have you guys with us to launch our brand new regulatory update webinar series that is targeted just for you all in skilled nursing facilities. So just a couple of housekeeping items before we officially get started. Since there are a lot of you with us today, we are excited that we have record number of registrants today. So with that, your lines are muted. However, we welcome questions and we'll be happy to answer those at the conclusion of the presentation should we have time. So you can send those questions to me and I'll make sure to ask Jane. Using the questions window that's on the right side of your screen. You could also send it via chat, but questions is a little bit easier for us to make sure that we get them all answered for you. We also are recording today's broadcast, and we will send a copy of that in a follow-up email along with some corresponding materials. So if you are new to our series, I'd like to just say a couple of words about our company. Casamba is the largest provider of software and solutions to the post-acute therapy space. Through our smart direct bill, therapy source, rehab toolkit, and HealthWise solutions, we now serve over 12,000 locations across the country, and those include outpatient clinics, home health and hospice agencies, and of course, clinicians in skilled nursing facilities. So to introduce our host today, Jane Moffett is a registered nurse by training. She has over 20 years of experience in the acute and long-term care settings. Throughout her career, Jane has helped healthcare organizations design and apply technology solutions to address the critical needs and challenges that are faced in facilities. As our Chief Product Officer at Casamba, Jane leverages this knowledge to help build and deploy solutions that add real value to post-acute organizations across the entire continuum of care. So without further ado, I will turn it over to Jane to officially start our first SNF regulatory update. Thanks, Jane.
Thank you, Megan, and thanks everyone for joining. The hot topic of the current is RCS, and there has been quite a bit of discussion throughout the industry about what this means for our SNF settings. And this is part one of a series of what RCS is. It's a complicated subject, and it deserves focus. And today we're going to start with an overview of RCS, why we're faced with this and what it is. We're going to talk about the case mix adjustment categories. And then we're going to pay some particular focus to the PT and OT case mix indices and the SLP case mix index. We're also going to have an opportunity to look at some early data analysis that Casamba has performed on actual MDS submission files. And then lastly, we're going to review the our plan, and that will be a nice lead-in for our second in this series where we go deep into the plan from Casamba's point of view. So let's just go ahead and get started. Why are we faced with this, and what is RCS? Well, CMS and MedPAC have long suggested that our current methodology of reimbursement is flawed. If you recall, we went from a fee-for-service into a prospective payment system, and that payment system did look and take therapy utilization into account, more so than much of the other clinical picture of the patient. We have seen some trends in recent years that have shifted from our initial prospective payment system to a more retrospective payment system, and we have experienced that with our change of therapy OMRAs, where we're looking back rather than forward at what was provided for therapy, and also the end of therapy OMRA. We have also experienced a change in a trend that seems to be moving us towards outcomes-based reimbursement. Although we haven't seen that actually happen, we are seeing CMS asking us to collect data related to outcomes, and of course we know that section GG on the MDS, and also in our Part B setting those G codes. RCS is a proposed prospective payment model that will use clinical characteristics from the MDS, data elements already being collected, as a way to calculate that prospective payment with no focus at all on therapy minutes. And of course, CMS and MedPAC's goal is primarily to address concerns related to therapy utilization. We have seen a focus there in our PUF report and also just various dialogue that both CMS and MedPAC have shared with the industry. CMS's goal is also to maintain simplicity and to decrease assessments rather than increase, hopefully to decrease the burden on our skilled nursing facilities. CMS's goal is also to use data that was already being collected in this new prospective payment system. And then finally, to accurately compensate in our setting based on the complexity of the patient. And so this RCS model, through the work that CMS did with Acumen, has been formulated with these goals in mind. CMS made some assumptions when they produced the report, and actually through, again, the contractor Acumen. And those assumptions were that the patient's population would be the same. We'd be seeing the same kinds of patients in our skilled nursing facilities, that the provider behavior would remain the same. In other words, the providers would accept the same kinds of patients and would treat those patients in the same way. The assumption was also made that the MDS would be coded the same way it's been coded historically, and that the patient outcome, the payment outcome would end up being budget neutral overall. And these were assumptions that were communicated in the Acumen report and also, again, in dialogue through CMS's discussion with the industry and also open door forums. So let's talk about how RCS will work. And remember, we're not taking any minutes related to therapy for our prospective calculation. So the idea is that data elements from the 5-day assessment will be collected and will run through a grouper. And this grouper will produce 5 different case mix indices. Those case mix indices are a nursing CMI, a non-therapy ancillary CMI, commonly referred to as an NTA, a PTOT CMI with PT and OT grouped together, an SLP CMI, and then finally a non-case mix CMI. And those 5 case mix indices, the values from each of those will be summed up together and will run through additional variables related to urban and rural in much the same way that our traditional RUGS classification went through to produce a daily rate. So the outcome of all of this calculation is a per diem rate paid for each day that the patient is in the facility where the payer is Medicare Part A. In PT and OT in particular, and also ST, remember, Section O is not used at all. So let's talk about how each of these are calculated. First of all, from a nursing CMI point of view, we continue to have 43 possible classifications. That has not changed. Same data elements would get you into a classification, and there are still 43. What has changed, and this screen nicely illustrates it, is that the weighting from a CMI point of view in RCS is actually going up. So if you look at the third column, that nursing case mix index, you can see where in our first RUG-4 category, ES3, we would have the patient move from a 3.58 index to a 3.84, and that is consistent throughout all 43 of these classifications. The next area where we are producing a CMI is the NTA. This gathers up all non-therapy ancillaries, drugs, labs, respiratory and medical supplies, and derives a point system based on conditions and extensive services found throughout data elements in the MDS. This one's a little bit more complicated. So what the grouper does is it runs through the MDS and it grabs data elements throughout, and for each of those where you hit the data element, you start adding points. So for example, patient has HIV or AIDS, that's a +8. If you add on to that IV medication, you'd add 5 more, and so on. Transfusions, kidney transplant status, and so on. All of these take those possible points on the far right and sum. And you can see how you'd need a grouper to figure this one out. And then finally, it takes that sum and it places the patient into an NTA score range. 11 plus would be those patients having the most hits on that list, and then 8 through 10, and so on. And then at the far right, you'd get the NTA case mix index. Let's continue on to our PTOT, and we are going to spend a little bit more time on PTOT and also SLP because those are the area of focus for most of us on the call. The PTOT CMI takes 3 major areas, and those together produce the CMI, and we're going to talk about each one of those. The first one is the clinical category. That's the first and most important piece, as you'll see. This clinical category is based on mapping from the diagnosis that is placed in I-8000A. Now, if you remember, Section I, the diagnosis area, has quite a few diagnoses in the upper part of I that are checkboxes. Does the patient have hip replacement? Does the patient have spinal surgery? Was there a CVA? Okay. This particular piece, the clinical category, does not use any of those checkbox areas. Instead, it derives the clinical category from the ICD-10 code placed in I-8000A. And historically, that particular data element has held no importance. So based on the diagnosis found there, it maps it back to a DRG, and there are more than 150,000 ICD-10 to DRG code pairs. Not really a way for our typical MDS coordinator to know this by heart. It maps it back to a DRG, and then that DRG will pull it into one of 5 clinical categories: major joint or spinal surgery, other ortho, non-ortho surgery, acute neurologic, and medical management. So the first thing that happens with respect to PT and OT CMI is that diagnosis is pulled and a clinical category is defined. The next piece that is used to calculate this PTOT CMI is the functional status. And this piece goes into the MDS, Section G, and looks at ADL self-performance for transfers, toileting, and eating only. It pulls those answers and adds them together to generate a score between 0 and 18. The higher the score, the higher the CMI and therefore reimbursement. And then the last piece that the PTOT CMI uses is cognitive impairment. For this piece, it reaches again into the MDS, looks for either a BIMS score or a CPS scale score. And the more impairment it finds in these, the lower the reimbursement becomes. The idea is that our patients who are cognitively impaired are less able to consume PT and OT services, and so therefore would receive less of those services. So to summarize, the grouper goes out and calculates a clinical category based on the diagnosis that happens to be found in I-8000A. Then it goes into Section G, looks for functional status, sums up 3 areas, and then finally goes in and looks for cognitive status based on either the BIMS or the CPS. Those 3 together become the CMI. And here's how it pans out. You can see on the far left, we've got our 5 clinical categories. That second piece, function score, that's your Section G. And then that third column, moderate, severe cognitive impairment, yes, no, that comes from either the CPS or the BIM score, and that's a flag. Those 3 together then determine the case mix index on the far left. And we can see that area of importance or importance is primarily placed on the clinical category the patient falls into, with major joint replacement and spinal surgery trumping all others, followed by other orthopedic, acute neurologic, non-ortho surgery, and then finally medical management at the furthest down. Each of these clinical categories, of course, factor in function and cognitive impairment, but that clinical category is really a key piece here, and getting that right will really influence that CMI score. And we can see that when we look at the arrows there. Our maximum CMI score for other orthopedic, for example, is 1.70. That's the highest we can get. So if we miscoded I-8000A and put an other orthopedic in rather than a major joint replacement, all other things being equal, we would fall much further down in our CMI index. The next piece we're going to talk about is the SLP CMI. Similar calculation, fewer clinical reasons, so fewer clinical categories, and different variables that influence those 3 scores. So we'll take that clinical reason for stay to produce a clinical category. Then, and there are only 2 of them, is this an acute neuro or a non-neurologic? Again, the same diagnosis on the MDS is used to determine this piece. So if you have a patient who has a hip replacement and also an acute neuro diagnosis, and you happen to put the acute neuro diagnosis in I-8000A rather than the hip replacement, you are going to reduce your CMI index significantly. The next piece then to determine your SLP CMI is the swallowing or altered diet. This goes in and checks those data elements on the MDS looking for conditions where you have both an altered diet plus a swallowing disorder, either of those, or neither of those. And there's a score related to that. And then finally, the SLP CMI goes in and looks for comorbidities and cognitive impairments. To look for comorbidities, it looks at all of section I-8000. So that would be I-8000B through J. And then it also reaches in and determines whether or not the patient has mild to severe cognitive impairment. Interestingly enough, for the cognitive impairment piece of SLP, it uses a different kind of calculation than the same cognitive impairment for PT and OT does. So again, from an MDS coordinator's point of view, it would be very, very difficult to memorize how these calculations occur. The SLP comorbidities that I mentioned are listed, and they do use I-8000B through J, we believe. But there are also other of these comorbidities that are simple check boxes in the upper part of section I. And so it's not clear yet how that data will be used to determine if there is a comorbidity. Any single one of these comorbidities gets you into the comorbidity category. And the absence or presence of comorbidities does have a major effect on the CMI for speech as well. Any kind of comorbidity plus cognitive would actually increase the CMI. So where a cognitive impairment decreased a CMI for PTOT, that same kind of cognitive impairment would increase the CMI for speech. And these are the possible speech CMIs. So we've got just two clinical categories, that acute neuro and the non. The presence of our swallowing disorder or mechanically altered diet, and you'll see where it says both, either, or neither. So for each of those clinical categories, then, you've got 9 potential combinations of swallowing plus diet. And then you've got your SLP-related comorbidity or that mild to severe cognitive impairment. And again, that's a both, either, neither situation. And then that brings you down over to your case mix index. So what else about therapy then do we need to think about as if that wasn't enough? Some other conditions that came out of the proposed model are related to concurrent and group. Concurrent therapy would be limited to no more than 25% of a resident's therapy minutes. Group therapy limited to no more than 25% of a resident's therapy minutes as well. It was not clearly defined, though, how they are going to restrict the use of concurrent and group. In other words, would this be measured daily? Would it be measured for the entire Medicare stay? Would PT and OT, all their minutes, be put together since we're CMIing out together? And would the combined PT-OT minutes for concurrent and individual and group be used for these calculations? Would all three be put together? The only thing we do know for sure is that more than likely all of the minutes for therapy during the Medicare stay will be reported once, and that will be on an end of Medicare OMRA. So we know for sure, or at least it's been very, very strongly suggested, that while we're going to collect data elements on our 5-day to produce a CMI and therapy is not a factor at that point, that end of Medicare OMRA will report therapy minutes for the whole Medicare stay, and more than likely some sort of algorithm will run for those data elements to determine concurrent and group allocation. It's also important to remember then that what this means is that CMS will know how many minutes of therapy each patient got for every CMI classification. And they will be looking at that data closely to see if their estimate of the weighting from a clinical category point of view that was made based on data they have today caused a change in behavior from the clinician's point of view or from the facility's point of view. Additionally, for PT and OT and also for the non-therapy ancillaries, the Acumen report recommended or found that resources related to both these areas decreased throughout the length of stay. And so therefore, they are proposing that payment would decrease throughout the length of stay. Let's talk for a second about PT and OT. I know NTA is a factor, but we're going to focus on our therapy piece. For therapy, you know, the idea is that in the past we have done a 5-day, a 14, a 30, 60, and a 90. In the last several years, we've had to also report change of therapy OMRAs. And those assessments have shown, in many cases, that as the length of stay increases, the therapy utilization decreases. So we might be able to explain Acumen and therefore CMS's theory based on that. From from an NTA point of view, somewhat could be explained as well. What the payment model suggests then is that that per diem CMI get adjusted down as the length of stay progresses. And so for PT and OT, the proposed model would take that payment at 100% from day 1 through day 14, and then have that rate go down 1% every third day afterwards. There is no adjuster for ST. So if we look at our grid here, we can see from Medicare payment days 1 through 14, we have 1.0 basically translates to 100%. 15 through 17, you multiply that rate by 99. On days 18 through 20, you'd multiply that rate by 98, and so on. Where if the patient did have a 100-day stay, then you'd multiply that full rate by 71% to get your daily per diem. And that, again, is related to PT and OT. NTA has a different calculation. It's basically multiplied by 300% for the first 3 days and then goes down progressively. So as I indicated early on, all of this data comes from a 5-day assessment, and it is prospective. So it's going to take that 5-day MDS and determine these 5 CMIs, sum them together, run through with additional variables to produce a per diem rate. And that will be the rate that the facility is paid in order to provide services to this patient. That'll be based on that 5-day PPS. That ARD is days 1 through 8. Typical behavior is to, sort of begin collecting it and submit it anywhere between day 14 and onward. In the current methodology, of course, we always had our therapy minutes right away, and we're planning for those. So from the perspective of the therapy department, we really had our marching orders on the type of therapy we should provide to the patient based on that plan of care. Well, now that therapy CMI is going to really be determined by factors outside of our control in the therapy department. And although as part of the interdisciplinary team we have an influence on them, we're really not directly influencing those values. The only way that that prospective payment could change is if the patient experienced a significant change in status. And those rules right now have not been slated for any kind of change. So that's a significant change in 2 or more areas and the definition around that are pretty strict. And then what that would do is it would take the ARD of the significant change, refactor that through, and then potentially change the CMIs based on that. And then finally, the last assessment that we really will be required to produce will be that PPS discharge assessment. And the rules around that don't change. That's the most recent assessment that we're required to complete in order to get the section GG end of Medicare values. So that assessment remains. And on that assessment would be the only time that therapy minutes would be reported as well. So we would reduce our PPS schedule to its current methodology where we have 5, 14, 30, 60, 90 interspersed with change of therapy OMRAs, end of therapy OMRAs, and so on. And that gets pared down significantly to a single 5-day assessment, significant change in status assessment when appropriate, and a PPS discharge assessment. If you had cause to read the Acumen report, there is a nice large section there that talks about potential ways that people might abuse this prospective model. And one of the subjects of discussion is the thought that a facility who CMI'd lower might discharge the patient out and then bring them back in with the sole purpose of redoing their 5-day and adjusting that CMI. And Acumen has some discussion on that, and it's been discussed in some of the open door forums as well. In order to mitigate that, there is also a proposal that an interrupted stay policy would be implemented here, and this would be similar to our skip days that we're familiar with. In today's world, if the head's not in the bed at midnight, you don't necessarily have to discharge the patient. You can just not bill Medicare that day, and when the patient comes back in, you can continue on with your Medicare count. Same kind of thinking here. If the patient leaves the building for less than 3 days, then there would just be skip days applied, and when the patient comes back in, their CMI calculation across all 5 areas remains the same, and their day count resumes. And again, this is to mitigate the thought that perhaps some facilities might send the patient out just for the purpose of allowing a new 5-day when they come back in. So that's been kind of a whirlwind on what we're dealing with here, and there are major impacts to how we collect the data and also how we are able to, as an industry, interpret the CMI and provide services to that same patient, because the patient didn't change, in a way that continues the spirit of RCS, which is that behavior wouldn't change, the patient's profile wouldn't change. So challenge number 1, of course, is that we've got CMI scores now based on data from an assessment that historically doesn't even get completed until after day 7. As a therapy partner, of course, we know right away, we've got that plan of care, we have our the plan from a frequency and duration point of view. We're planning for the patient. We have a lot of knowledge on day 1, day 2 about what's going to happen with that patient. Of course, we're still going to see that patient, assess them, and lay down a plan of care. But now, we won't really know if the plan of care at all resembles the CMI score that we're going to end up with for therapy based on those variables outside of Section O. And we may not know it until day 15. Challenge number 2, of course. Therapy payment is no longer based on therapy. Again, we've got these external variables that are producing our CMIs for PT and OT grouped together, and then for ST by itself. Not at all based on utilization of therapy, the therapy plan of care, the functional deficits and underlying impairments, the short-term goal of the patient, not at all factored in at all. Challenge number 3. We have RCS roulettes. We have a single field on the MDS, I-8000A, which prior to RCS held no particular significance to anybody, being used as a driver for clinical category, and that field has speech competing with OT and PT. So a patient who has both a speech clinical problem and a PT-OT clinical problem, only one of those is going to land in this field. And it would be very, very easy to get the wrong one in and have the patient's CMI reflect resources that really don't show the clinical picture of the patient. Challenge number 4. For our contract therapy partners on the phone, how do we bill for contract therapy? How do we become a partner to the facility, risk share, provide the amount of services so that that patient gets what they need and outcomes aren't affected? Because Section GG continues to be reported on that 5-day and also on that end of Medicare assessment. And then finally, that end of Medicare assessment is going to report the actual amount of therapy that was provided. And so CMS has modeled out a plan based on actual assessments they've run through their proposed grouper, and through that, they've calculated CMIs that they feel reflect the amount of therapy that was already being provided to these patients. Now, we're not having to report therapy throughout the length of stay anymore, only at the end. CMS, as we all know, has really gotten to the business of data mining. And there is an extremely high risk that if behavior does change and we don't provide therapy services like we did for this same kind of patient prior to the implementation of this model, that we could experience significant post-payment audit risks and clawbacks. We also always have to think about the other thing, which is the patient. That kind of patient had a level of therapy provided to them in order for them to increase their self-care and mobility and be able to get back into the community or reduce the level of services that they needed. And that patient profile has not changed. So we also have to be sure that from a therapy perspective, we provide the amount of therapy to get that patient back where they need to be. And these 5 challenges, these are real challenges that this model has. We need to be able to find a way to mitigate all 5 of these challenges and come up with a way to provide services for these patients and for our partner facilities in a way that provides the standards of care that the industry has come to expect from us. So let's talk for a second about what we here at Casamba have been doing to see what happens with these assessments. What we've done here at Casamba is we have created the algorithm that can produce all the CMIs, and we have done that using the Acumen report and also the flow sheet, that RCS model calculation worksheet that CMS provided for us a couple of weeks ago. What we've done is we've created that grouper, and with some of our partners have pulled in actual MDS submission files and run those through the grouper. We have a nice advantage here because not only do we have submission files, but for that same patient, we actually know what kind of therapy was provided throughout the entire length of stay. And we know all the other assessments as well. What was on the 14th day? Were there any change of therapy OMRAs? What did we do throughout the length of stay here from a payment perspective? And the first thing we did, of course, was we run it through the grouper based on that actual diagnosis that was found in I-8000A. Remember, that field had no particular significance prior to this and was really based on whatever the MDS coordinator decided that they were going to stick in that field. And in our early data analysis, what we have found is that 52% of the patients had a diagnosis in other fields of Section I that would have qualified them for a clinical category where the resources were higher. And in 53% of those cases, the incorrect clinical category was medical management, which gets us to the very, very lowest CMI. So let's talk about that for a second. We had a very small data set because we haven't gone full force with this, but enough data to see a trend. In more than half of the time, that diagnosis in I-8000A didn't really match that patient's clinical profile. We didn't invent any of the other diagnoses. They were all sitting there in Section I, but they were in different areas. So the patient didn't change. The only thing that changed was that diagnosis in I-8000A. That's very, very important. We call that here at Casamba RCS roulette affectionately. We've been dealing with this for the last couple of months, talking about this and really trying to figure out how affected are we going to be by this. And if we take like assessments, like behavior, and don't change coding, huge significance in this area. For those very same patients, 98% of them had other diagnoses in Section I that could have put them in more than one clinical category. So of course we know about our 52% where we had two clinical categories potentially and an opportunity to put them in a resource area that was more fitting to the patient's picture. In all but 2%, we had multiple clinical categories, and in some of these assessments, we hit all 5 clinical categories. Now remember, more than 150,000 diagnosis to DRG code pairs. There is no way that an MDS coordinator will be able to memorize where to put diagnoses in I-8000A. When we started to look at the data and we said, all right, so what does it mean exactly? And this is just a subset of our highest hits here. Those CMI differences were pretty significant. First of all, not a single hip fracture actually landed in I-8000A. That's because those diagnoses are one of the checkboxes above. So although we had quite a few hip replacements, none of them hit the right category. Many of those very same patients found their way into medical management, which would not have provided us the resources that we need to provide high-intensity therapy to our hip replacement patients. So as we look at each of these, what I did is we just pulled in and said, for the correct resource allocation, if we, out of all the diagnoses the patient had, if that correct one landed in I-8000A, and we compared it to what was actually there, what kind of differences did we see? Our widest range was 1.82 to 1.55. And remember, those CMI indices run through other variables to produce dollar amounts, and that's pretty significant. 1.82 to 1.7. In some cases, 1.7 was correct, and we actually had 1.61, and so on. And we're going to see findings like this, we believe, when we start mass analyzing all of these submission files for you, our partners, so that you have a good idea of how important it is, and you can begin to come up with a plan on how to partner with your facilities to actually get the correct diagnosis where it needs to be. Megan, can we do a time check real quick?
Absolutely. We have about 17 minutes left.
Okay, great. So we have an opportunity to probably take about 5 minutes of questions, and then I'd like to talk about what our plan is. I'm sure the group has by now realized that we have the ability here at Casamba to take submission files and run some data analysis, and I want to talk a little bit about our plans around that, as well as those other challenges. So Megan, if we want to open it up for about 5 minutes of questions, I'd love to do that before I talk about the plan.
Absolutely. So one of the questions that has come in is, would Casamba alert if the group or concurrent minutes are approaching 25%?
That is a great question. We absolutely will. We will have our planner properly interpret what the final rule is related to individual, concurrent, and group. And we will help you do that based on, again, the CMI calculation and the resource allocation. I'll talk about that a little bit more when we talk about what the plan is for Casamba, but there would definitely be an alert and some guidance.
Thank you. Another question is, please clarify the justification of decreasing reimbursement after 14 days for PTOT.
We don't actually know the real justification for it, but we believe when we look here at Casamba at length of stays and RUG scores, and in particular the therapy component of RUG scores, that there is sometimes a trend where the RUG level goes down as the length of stay increases. Now, we don't see that in all of our partners, but we see that in enough of our partners where potentially this is the reason why Acumen came up with that conclusion. And again, these are their conclusions based on massive data mining efforts that they have been doing on actual assessments.
Thank you. Another question that has come in is, if minutes are no longer a guideline for treatments, how do we determine the intensity of therapy that a patient needs?
Very good question. What we're going to be doing here at Casamba is we are, of course, pulling in the CMIs, and we are doing analysis on the actual rates associated with those CMIs for the therapy component. Theoretically, then, we would be able to determine the amount of minutes for therapy that Medicare used to determine those CMIs and the rates associated with them to provide some guidance back to you. So if I had a CMI of 1.82, we know based on the actual reimbursement that this would relate to X amount of minutes of therapy, and that would be a guidance that you could use.
Okay, I think we have time for probably one more question. This is one that's probably on everybody's mind, is how likely is an implementation date of October 2018 for this proposal for RCS-1?
October 2018, if you mean
yes.
Fiscal year 2018, which happens this October, not likely at all. If you mean actual date of October 2018, which would be fiscal year 2019, there would need to be quite a bit of work on CMS's side with respect to guidance on MDS, MDS data elements, grouper changes for all the state-specific software. It's a large amount of work that they have to do on their side. Historically, what we've found is when they come up with a proposed final rule and then end up postponing it, it's because their own software is not yet ready for it. So, we have to weigh that in as well. Additionally, on the last Open Door Forum, there was a comment made by one of the CMS principals that that this would be a longer implementation rather than a shorter one. How we interpret that, I'm not sure. I do think, though, that we better be prepared for it. We better have a good story to tell. We better really get prepared to show why therapy makes a difference and should not be considered to be a cost center, but should rather be considered to be a full partner. Of course, based on the fact that we need to maintain and have outcomes be better, but also the potential clawback. So circling back then to what that question was, how likely? It would take a lot of work for CMS to get prepped for this. We'd have to see very intensive action around this, coupled with very intensive publication of things like grouper logic and supporting tables so that the states and their provider, their own software can get ready, but also each of the vendors can get ready. So we'd really have to see a big tick up in intensity of them sharing with the specifics in order to meet that date as well. And I know that you probably are looking for a better answer than that. I'm really in the position that most of you are as well, members of committees that are working on this, really sharing intel and interpreting data that CMS has chosen to share with us. Still pretty vague in a lot of their sharing yet. And so I don't have a good answer. I can really only base it on what I'm hearing from the industry and also my other peers in the industry. So with that, then, let me just talk a little bit about Casamba's plan. Alrighty, so the first thing that we're doing here at Casamba is providing you, our partners, a way to collect objective data related to RCS. And we're going to talk more about that. We've been working with some very close partners with getting submission files and processing them and looking at that data. First of all, in order to just test that we've properly interpreted, the Acumen report, and also the RCS model calculation worksheet, because as I mentioned a few minutes ago, we don't really have specs from CPS on the grouper. And also just to compare that with what we have inside of Casamba. And we're going to continue to do that. Very soon we'll be opening this up to all of our partners to allow those of you who are able to be able to upload submission files. Our grouper can process thousands of submission files very, very quickly. What it does is it first runs it through the algorithm looking at what happens to be in I-8008, and then it gathers the rest of I and runs it through the algorithm again to find out, based on that total clinical picture that we already have on the MDS, what would really be the correct diagnosis in I-8008 to represent the resources that that patient needed. So we'll have our happen to be I-8008 and then the correct one. And then the second thing that we are doing is we're finding that very same patient inside of Casamba and laying down that length of stay and showing you what you actually provided and comparing that to the CMI. We feel like this is just going to be a really important tool for you to illustrate what kind of therapy was provided to these patients based on this clinical picture. Now that's for now. What happens if we really do get there and we really are in an RCS situation? Well, because we're using data elements from an MDS collected and typically reported well into the stay, we really need to find a way to collect that right on admission or even pre-admission to understand how we should treat this patient based on their clinical picture. And so we are also developing an MDS RCS collection tool that you as a therapy partner will be able to do. Very short screening tool that will show you where the patient CMI'd out with respect to PT and OT, speech, and also, if you choose, the other CMI areas, nursing and NTA and so on. We imagine that some of our partners will want to focus just on PTOT and speech, but we may have others who want to use this as a total comprehensive tool and really look at the whole patient. And so we will have both of those available, and we will be looking at running that data so that we can avoid what I've been referring to as RCS roulette. Because remember, that patient profile on that assessment really didn't change at all. These are diagnoses that already exist for this patient and were found in Section I, just not in Section I 8000A. Once we have that data and we know, then we'll be modifying our software to use it. And there'll be a couple of ways where we will be using it. An important way is, as one of the attendees queried, guiding you to understand, based on the CMI, what kind of historical therapy was provided to this patient so that we can guide you in planning the frequency, duration, intensity, and type of therapy that's appropriate for this patient. And of course, that's a guide, right? State practice acts, they don't go away. Clinical decision-making doesn't go away. But it is important to know from a reimbursement point of view and also from an expectation from CMS's point of view, since they are in a major post-mode audit, really where they see this patient as well. Where you expose this will be up to you as an organization. You may want to keep this up in the upper management area and not communicate this down to your therapist. This will be something that Casamba will really allow for you to use in the best way for your organization. And then for our contract therapy partners, we're really going to start working on creative and innovative ways to partner with your locations, with your facilities on contract therapy in particular. You know, obviously the model today, which was a per diem RUG based on the therapy component of the RUG score, doesn't really make sense anymore because we're not reporting minutes anymore, and those calculations that kind of backfilled that in, they don't really exist. And there are several ways that our partners have talked about potentially modeling this. Everything from a per minute rate, a per patient day rate, a per patient day for all patients, no matter what CMIs are, per patient day based on CMIs, per patient day based on a combined CMI for PTOT and then adding speech. That same kind of methodology with a full rate for the whole length of stay. That same kind of methodology that would titrate down for PT and OT. So really a lot of potential ways that we can partner with facilities to be sure that we provide the services for the patient because the patient didn't change. We reduce our risk from CMS's point of view with how we provided therapy, and we also maintain those outcomes that we know we're probably going to be held to very soon. And so these are our plans. So for our next in the series, we're going to dive deep into each of these areas and show you what we're doing for that so that you as our partner have an idea about what to expect. And we'll also share with you some deeper data analysis. We'll dig deeper into assessments that partners, that our pilot partners have been able to upload, and then show you some of our proposed screening tools so that you have an idea of where we're going with that, and talk more about how that will interact with the SMART software from a planning point of view, how those CMIs will affect documentation and be able to do some guided documentation based on the CMI potentially, and really start talking more about creative ways that the therapy department can partner with the facility in the new model. And so with that, Megan, time check?
We have a few minutes left. So did you have anything else you wanted to cover, Jane?
No, I don't. I'm done. I'm not sure if there are any burning questions out there or if we're ready to close, but
well, if we did have lots of questions come in, and since we just have a couple of minutes left, I don't think we can adequately answer them for you. So what we'll do is have somebody from Casamba's team follow up with you directly. We're also going to produce kind of a frequently asked questions type document that will be a living type document as more questions come in with the proposal and of course into our second section, our second session. In the follow-up email you receive that will have the recording of today's broadcast and those supporting materials. Will also include a link to register for that next session. So we'd love to have you join us then to just do a little bit deeper dive into this proposal, and we will send that information shortly. It'll come via the email that you registered for today's session with. So we thank you for joining us. Thank you, Jane, for a wonderful presentation. Again, if you have any questions, you can always reach us directly. Reach out to your Casamba account manager, or you can ping our support team. We'll be happy to pass it along, but we hopefully can get you those documents soon and answer those questions for you, and we hope to see you next time. Thank you so much. Have a great day.